Brenna, are you ready for me to start?
Yeah, and not, it's redirecting here. So now you just need to.
Brenna, are
I didn't listen.
okay? I just heard myself. That was kind of weird. I don't know if there's a weak delay. Are we good?
We're going.
Okay. All right. Thank you for being here. We're going to get the NDPHIT board meeting started here. First item of business deals with the agenda. Do we have a motion to approve, or do we have additional items to be added?
So moved.
Okay.
Second, Kevin.
Okay, we have a first by Cole, second by Kevin to approve the agenda as presented. Any discussion? Any discussion? I'm just going to do it. If you're opposed to that, please signify by saying something or whatever. We'll just assume you're good.
Good.
Okay. All right. Agenda is approved. First item is the consent agenda item, which is the December meeting minutes.
So moved.
Cole with motion.
Second.
Second by Brendan. Discussion. Okay. If you're not in favor of approving this motion, say something. Looks like it's motion carried. Okay, item number 3 deals with the operational update. First of all, would like to welcome one new board member, but Kevin was reappointed, officially elected to a 3-year term because he was just appointed after Steve Hall's retirement on June 30th, 2023. So welcome, kind of, sort of, Kevin, back. Glad you decided to stay with us.
Been a pleasure.
Yeah. And then we have a new person, Desi Calahoo. Sounds like I'm saying that right, I hope. And she's a director of human resources in Dunn County. Desi, you want to say anything?
No, not really. Happy to be here. I'm excited to learn, pretty much.
Well, you came to the right place because it's every board meeting. We're learning lots. Okay, well, welcome. Thank you guys for agreeing to serve, and we look forward to working with you. We have item. Just want to make sure I'm looking at the right one here. Item B under operational update, and that's participation agreement change, and this will include some board action. I was kind of briefed on this, but I would like Seek and then also Randy to give us an update on the participation agreement change. You might be muted over there at the Seek office if you're talking.
Sorry about that. Yeah, so the participation agreement, for those of you that don't sign up personally, is signed by every member that comes into the trust. It just outlines their responsibilities and our responsibilities, and it's just we needed to update it for a few things. It still said the Bank of North Dakota in there, so we just took out that detail. And then a few bigger items like the COBRA administration has changed a little bit since we realized that no matter how big each of our members were, they all need to be doing COBRA administration because they're part of the trust. Another part that we added was some HIPAA language just to make sure everybody is going by the guidelines and knows that that responsibility is partly theirs. I think those are the 2 main things that we added. Randy, do you have anything?
No, yeah, it was some feedback from our compliance and then shared with Zach to make sure he was comfortable and covering the scope of the language that was suggested. And so then updating it accordingly.
Yeah, the NDPHIT attorney did review, so that you guys know, but it is a NDPHIT document that goes out to our members, so I believe you guys just need to have a motion to change it.
So pretty straightforward. Do we have a motion to approve the changes here to the participation agreement?
So moved.
Okay, Brennan,
1 second.
was that Kevin? Okay, Brennan and Kevin. Any discussion? Any discussion? Any discussion? If you are not in favor of the motion, please say something or indicate on your screen. Okay, it looks like it all went through. So that is approved. Thank you for that. We also have item C. We kind of keep leaving it on there. And I know we have some new members, so maybe we need just a briefing of what the board training is, and maybe some people that are interested in, can attend.
Yeah, I can just give the details. It's the new trustee institute. It's level 1. The next available is in June 24th through the 26th in Las Vegas. And for Desi or anyone who may have forgotten, NDPHIT would pay your expenses to attend this. I don't know if Brennan would want to share. He did attend it. But I know I've gotten a few emails on people that have been kind of interested. So.
Yeah, it just exposes you to some of the the issues that could come up while you're a trustee, and what your duties are, and all that kind of stuff. So it's a good foundational course to go through. So definitely recommend taking advantage of NDPHIT paying for the trip, and NDPHIT's not liable for your gambling losses, though. We got to put that disclaimer out if you end up in Vegas.
So Brenna, if you can't make the June date, you said, is there another opportunity at a different date and time?
I have to go look. I can send you guys the link again. I haven't sent it for a while now, but I'll send it out after the meeting and you guys can check it out. I checked and for this next available date, but I didn't go any further this morning, so. But yeah, I think it's an open item. If you can find the next one, if the next one works better, and you can go then.
So board members, if you are interested in that opportunity, please email Brenna and she will get you hooked up. Okay. Let's move on to operational strategy. Item A, NDPHIT wellness. We have an update for on-site screenings. This is something that we've been working on. And so I believe, Randy, you're going to give us an update on that. I think you're muted again.
Can you see Randy's screen?
Yep.
If I can make that work. So the on-site screenings that have been taking place, just so everybody has some context and information regarding that. So the ones that have been done through in 2023, 213 actual individual screens. These are the groups, and then 2024 January so far, they've already done 58. There were some done actually this week in addition to this, but I don't have that number. Had a meeting out this morning and know that those occurred, but just don't have the numbers on it. Just so you know, also, I share the same information with Blue Cross Blue Shield because they provided us the grant to do this. This is just a process overview of what is going on. So this is basically the member experience, and they're trying to simplify some of this as well, just so you know. That will continue to be refined because the bottom line is they have to create the best way to allow each person, when available, to actually to do this in order to participate and to qualify for the incentive. So in terms of the budget, so we're given $100,000 last year by Blue Cross. So far, or last year, I should say, we spent $30,840. 9% of that went to participation gift card incentives. Then they sponsored lunches for those, for some of the groups that were interested in doing it during the lunchtime. And then also travel, labor, and supplies. That was the rest of that. And then as I shared, that's the activity that occurred. And then the goal for this year is actually they want to do 500 screens. So that's the goal for 2024. And I'm not sure you can see this in the detail, but you'll get a copy of this as well. But this is the results of the body composition testing that was done on the 213 screens. The average age, 42.93. The bio wellness age, which is a calculation used by the standards that eVolt set forth in terms of they basically take all their groups worldwide, because they're a worldwide organization, and they set what's called a bio wellness age, which said if you are this age biologically versus your real age, that's the delta basically. So the goal is to stay at or below your the bio wellness age is to get below your actual age. But obviously our population is above that. Then the other one was the body fat percentage. So in NDPHIT, it's 33.14. The US acceptable range is 25 to 31. Obesity is considered anything over 32. So technically, the average of the population within NDPHIT is obese. And that's not totally uncommon for across the country, actually. NDPHIT BMI, 32.29. US 50th percentile range is 29.1. So we're about 11% above the US at the 50th percentile. Then the Bio Wellness Index. So that's another standard that is set by eVolt. They have a target at 10. And if you're below that target, that just means the incremental difference between hitting all the metrics that they evaluate to getting close to a 10. So we're at 6.69. So that's just some feedback. And this is something that actually Blue Cross was very interested in getting. Just because of the fact that they've actually never done body composition testing. And so this information was shared with their clinical team as well. So this is just a brief, next section is on the population health. And we have this set by our population health team in terms of the industry standard versus where NDPHIT is in these various components. So we look at the distribution of the population to what they call the low acuity, healthy, the moderate acuity, the high cost risk, rising risk, and then the complex catastrophic category. So just for comparison of where NDPHIT is in each of those categories, in terms of the percentage of the population, we have actually fewer number in the wellness or the low acuity, and the cost is significantly higher even of those that are in that lower percentage category. And this is coming from our Plan IT data. They basically stratify this using the Milliman reporting index. And so just so everybody knows kind of where the data is coming from as well. The moderate acuity is generally 15%. The NDPHIT is pretty close in that category and fairly close in the spend compared to the overall industry. And then the high cost category, we're slightly above as a percentage and slightly below in terms of our spend, which was an interesting one when I looked at it. The next one is probably the most alarming, and that is comparatively, we have 25% of the population that is in the highest risk complex cost category. In other words, a much larger percent of our population is in that category. Although the spend is pretty close to the total dollar, It just means that probability of both high-cost claimants and complex comorbidity claimants are going to continually be in that population category for NDPHIT. So the wellness initiatives basically are focused on the low to moderate acuity, whereas population health spans the entire group. And that's the initiatives of the multiple things that we're constantly looking at, both with the data and to programs that we are trying to engage with relative to the trust and its members. And just speaking to that, we brought this forward before, but Brown & Brown has a collective where we are identifying what are the best strategies for physical care and advocacy and engagement. We brought one of these to the table with E&I. They're one of those in the collective. But we will, as part of our strategy going forward that I'll share in just a minute, we will also suggest some others to look at in the future. So it just as a recap, Thriver health and wellness webinars and resources will continually be brought forward. We're constantly learning, as Angie would attest to. It's a process. There's been no perfect way to try to push out this information and have people participate. As we mentioned, E&I Next Gen for the EAP resources, promote the health screenings, the MCG webinars that's focused on the population that is 65 and older. The GLP-1, obviously, this year is our rollout for that program, and trying to measure the return on the investment for that. It will be critical. And then also there are programs that are relative that Blue Cross already offers our population. One of those is OMADA for diabetic care. So we're going to try to figure out how we incorporate more communication about that particular program because it's already in place. And then in the future, for 2025, we're going to bring forth the end of this year some of those strategies and vendor options that could be even more robust and available to members for musculoskeletal and chronic disease management. So with that as kind of the backdrop for population health, the next one is just to share some of our reporting data. And this is we still have what's called these gaps in care. This is all relative to some of that data that I just shared on the distribution of our population. So gaps in care still is a major issue in terms of the preventative care component. And there are multiple line items in these categories. And this is the whole concept between whether it's gaps in care for preventative or the chronic care. We're trying to engage as many of these resources that can actually help these individuals identify the options and to help them facilitate into the programs that are available to actually help them mitigate those exposures. And again, this is just the compliance level versus the prevalence. So it's that line across the board is the gap in every clinical category that is identified either as a preventative category or as a chronic disease category. And these are the chronic disease disparities, both those that are the members, the non-compliant, and our compliance percentage. And this is when we institute programs like the OMADA or the MSK, when you have this type of data that's available, if I were to click on the non-compliant category at the top for drug management or for hypertension individuals, our Springbuck report allows us to actually see all those individuals that are in the non-compliant category. And then it's collaboration for the vendor that can do outreach communications to those individuals. For example, diabetes of the OMADA program is, as I mentioned, is already available through Blue Cross. One of the things that we're going to, that can be done as an initiative in even OMADA is to have an engagement discussion about them, is to say, can we collaborate on sharing this information for a communication campaign? So there's multiple steps, and I won't belabor those steps today, but just to see, again, the purpose of today even is to just know in point in time of what's going on in our population and some of the relative initiatives that we are either recommending or continuing to be engaged with. This is just when we look at our population as the chronic disease categories and our trend over the years, asthma, as you can see, depression related, diabetic patients, the heart disease categories, blood pressure, and obesity. The top one essentially is that percentage change from year over year of the number of claimants. And then the one below is the average paid per member. As you can see in our heart disease category in 2023, it was the largest increase per member. And that's all tied in. Again, they're tied to typically what we call the comorbidities. That could be a diabetic and obesity. And it all ties into cardiovascular diseases. So when you have, and you can have a few outliers which drove up that cost, but just to see a trend where it's continuing to increase both as the percentage of number of individuals and for our spend per person or member that's doing it, those are important things that we have to know and also have a devised strategy about it. So this is another one that we are focused on in terms of the pharmacy. This first category is really a big one. Humira now has an alternative in a biosimilar. And yesterday or the day before, it was 2 days ago, on our call with Blue Cross, they were indicating that there's an opportunity essentially to create an edit process for availability. So if you're on Humira and there is a biosimilar that's available, which there are, what they're trying to do is get the biosimilars to be the first prescribing drug for the providers to recommend to the patients and get them transitioned away from Humira if it's clinically correct. And most of those biosimilars have that capability to do the transfer from that as Humira is the brand to the biosimilar. And just when we looked at the data just for NDPHIT, that's $845,000. It's a significant amount of money. And so we are going to stay close to Blue Cross to make sure that we can come out with even a campaign to get that communication out to those individuals who are on Humira and work with their providers who are prescribing it to get that transition if it can work out for them. Hold on a second, my thing just run out of power here. Maybe let's see. Sorry, guys.
Hey, Randy, I'm just going to kind of cut in for a second here because we're kind of shifting into population health. Did anybody have any comments, questions about the on-site screenings that Randy talked about?
Sorry, I got my power back up. The other one was just that, another one we looked at was just, this is an opportunity in the spinal fusion and joint replacement category. That's just another identifiable area that can be it's related to the musculoskeletal area. So when we look at vendors into 25, that would be obviously an area that we would focus a lot on. These are just some basic information just as updates. So that's just a point in time of where we see avoidable cost, both for the, avoiding ER visits. This is typically a plan design issue. When we still see co-pays at $50 for the ER, that's where we get frustrated because that's the reason they go. Why pay $25 to go to the urgent care when I pay $50 to go to the emergency room? So that's something that we're always constantly trying to get our member groups to consider their plan design and make the appropriate changes where we know that it's both the right thing financially, but more importantly, it's the right clinically thing to do for accessing the right care at the right time at the right place. And then just so you can see kind of what's going on overall and who's spending the money on an increased basis on the plan. And this is cost per employee, but broken down by employee, spouse, dependent, and then the pharmacy. Just again, as a point of time of reference of what's occurring in the trend. Now, this one's busy. I guess I took the data on the left and summarized it as follows. Our critical index, a risk index for our population from 2021 through 23. This is the Milliman risk index that's saying what is the change in the population relative to cost, to demographics, and to trend. And where do we see this going? And essentially, the clinical risk factor of our population, and I think the data that I've shown you before or in prior slides is validating this, but it's increasing. Our paid per member cost in that same time period is increasing. Age 65, this was the one that we constantly watch, and that's why we the MCG program. The number of our 65 population is actually increasing, which is, that's a challenge. Because when we look at our cost per member on the 65 population alone, you go from even in 2021 to 2023, 8,016. And the overall population is almost half that cost. In some cases, depending on the group, it's a third. So this is why we focused on the MCG program and will continue to focus, because not only are they more per employee or per member per month more per year, but the risk on the stop loss is always significantly higher with that population than those under 65. This is our distribution in terms of our population of the average claim that's being paid per member. So if you look at the summary of this, really it's 12.88% of the population accounts for 76% of the claims over $10,000. And then 2.4% of the population account for about 45% of the spend. So when we talk about these plan design changes, and when we're making the recommendation to go to the maximum out of pocket, when we see that migration of the population that generally leaves, it is proportionately higher of the highest cost claimants that leave the plan when you change their out of pocket from a $3,500 to a $9,500. If they have an option, they will take that alternative and move. And so we've seen that, and we shared some of the data last year. We'll give an updated report. Since we just finished the open enrollment in March, we'll have an updated report to show you the groups that we did make that change with on their out-of-pocket and the migration of their population. So anyway, we'll have more information on kind of our strategy on the plan design relative to the distribution of those claims and to those specific groups who made those changes for their plan. So the next section is before I go to this one, does anybody have any questions on the data of where we're at for that I've shared thus far?
Can you guys hear me? Can you guys hear me? Brenna?
Yes.
Yeah.
Okay, I just want to make sure. Okay. One thing I would just recommend, Randy, when you're like I'm just thinking with prescription, I have no idea what Humira does. It just would be helpful. Like, what does that do? Maybe others do, but I have no clue. It seems expensive, so it must be something that is very needed.
That's a good point, Mike. And there are, if we were to go over the top 10 list of the pharmacy list, I mean, so Enbrel and Humira are in the same drug class, and essentially they are, for clinically, I should say, and maybe that's what you're asking. I want to make sure I understand the question.
What would you take it for?
Yeah,
What you have and then take humor.
yeah, and there's a kind of a broad spectrum of, so if you just, the best way I tell, clients when they ask me, I said, Google it, and you'll see a list of probably 8 to 10 categories that are being used for these drug classes. Humira and Enbrel are typically in that same class, but they cover anywhere from, I'd say 8 to 10 different clinical conditions. And what's occurring, if you look at kind of the
Arthritis?
what's that?
Arthritis?
Arthritis is
Bones
probably
disease?
the number one area that they're covering clinically.
Yeah,
Yes.
just lists a lot of things.
But it's somewhat related to both the musculoskeletal and kind of progression that happens that leads to arthritis. I mean, so if you were to look at a patient over a period of time to when they started taking that, you would see a clinical history that kind of leads up to it. And a lot of it's musculoskeletal and sometimes it's diabetic related, but it can be a disease progression that ultimately leads to that high cost drug. So I may not have answered perfectly, but the simplest way is I'd say Google some of those categories just because it can vary by that patient class that's treated within it.
Okay, thank you.
The next one is the GLP-1. This has been obviously our hot topic for the last several board meetings. So I thought that we would give kind of an update of just comparative to, we looked at the data through the end of the year to see if it was close to what we were forecasting. Unfortunately it was. And so you can see the spend in 2022 versus 2023 on that in the second kind of box down there. And what's important about this too is to classify it. Mounjaro is a diabetic class GLP-1, and you have Ozempic, which is a GLP-1 diabetic class as well. So you kind of have to separate those class of drugs from the Wegovy, which is your anti-obesity class. And so keep that in mind as we go through some more of this discussion, because that's going to be important when we get to the end for our recommendation. Again, the other thing that we wanted to do was to actually look at the entire spend of money that was, that being medical and pharmacy related for these same patient classes. And what was, what you can see essentially is, and then what are we paying per person in each of those classes as well. So the box in the middle is for your diabetics. The box at the bottom is for your non-diabetic populations. Okay, so if you go just to the middle one and you add medical plus the GLP-1 class of drugs, we're spending about $13,000 per employee per year on the diabetic class. What actually really surprised me, that I've not seen the data like this. Our anti-obesity class for both medical and the GLP-1 drug spend is $36,000 per member per year. I didn't drill down below that medical spend, which is so much more significant. But what I think it is a lot of musculoskeletal. Because think about, there's so many different surgical, cases that could be happening to those patients that are in the obesity classification that's driving their cost to be 3 times what our diabetic population is. That's really a shocking number, to be honest. So what does that mean? Well, I'll get into some of that in just a minute. But just keep in mind, what we're seeing is the evolution of, what I would say multiple conditions that are going on within that obesity population that are driving that up. And the reason that they're probably even being prescribed the GLP-1s is obviously dealing with probably the most prevalent thing, which is the obesity piece of it. So just to give you a snapshot on where we ended the year on just that classification drug. This is data that we participate obviously in the Springbuck kind of aggregated reports, and because we're using their platform for our data, so they shared with us what's going on in their entire data. So you're talking about thousands of employers that are participating in this throughout the country, and so what they identified, which is kind of at the bottom, an 18,800% increase in the Mounjaro claimants per thousand, and a 386,000% increase in the Wegovy per thousand claimants. So again, Mounjaro is a diabetic class, and Wegovy is the anti-obesity class for the GLP-1. That was just over the prior year. So this, when we brought this up over a year ago, I'll get into the Blue Cross discussion in a minute, but I can just say Blue Cross is so far behind the curve in terms of anybody else in the country as to dealing with this. And unless we push it to them, in fact, I'm not even sure they had it on the radar to really make any changes. I think you guys were on the call with them. And it's just, it's just unfortunate, but it is what it is. So knowing what we know and where the trend is, this is just to give you some prevalence in their data of what's occurring per member per month increase on the GLP-1s for the anti-obesity and the diabetic class. And this is in the Springbuck database. So participated in another webinar actually yesterday that this is an interesting statistic. And that is that of the total, the demand essentially for GLP-1s based on CDC and the Kaiser Family Foundation, they're only addressing really 4% of the entire available population that currently, in other words, that gap is so wide right now, and it's growing because the number of individuals that are becoming in that obesity classification. So this was by, again, CDC and the Kaiser Family Foundation, which the Kaiser Family Foundation, just so everybody knows, is it's an aggregator of data across the country that they look at it by state, they look at it by healthcare related trends, and they're used as a very widely sourced data source, if you would, for employers and healthcare providers across the country. And this is an interesting comment by Novo Nordisk. They're the manufacturer of the Ozempic and also the Mounjaro. So said if I knew how big the demand would be, end up being, I could tell you, but I have the sense that it could actually take quite some time, some years before we have actually fulfilled the demand. Well, you saw on that prior page what the demand is. That's the unmet pent up demand. So given all this, all signs point to the huge impact on GLP-1 agonists have had on the increase of overall drug spend due to the brand name drugs and the marketing, social marketing that's going on there. So where's the industry going, and how does that incorporating what we're recommending and what we're actually doing? So just as a point of context, I think it's important to know what the industry is doing, what Blue Cross is not doing, and what we have to do. So some of them are not covering the anti-obesity classification at all. So those would be the Wegovys and the Zepbound class. Now, Zepbound has not been approved by Blue Cross at this time, so Wegovy is their anti-obesity class that is available. Most of them have gone to, it requires pre-authorization. A lot of them have gone to what's called step therapy, if you do make it available for anti-obesity. And I will tell you, the Digby approach really is those two things. It's going to require a pre-authorization, and it's going to require kind of a step class evaluation to determine if somebody even qualifies for a GLP-1. It's also, the industry is incorporated lifestyle and behavior intervention for anybody who would be qualified to be a part of the program, which is also, and we'll get into a little bit more detail about the Digby structure of how they're doing that. And then the other thing that came up in this webinar was that compound pharmacies are being viewed as a procurement option for employers. And why? Because there is an FDA emergency order since 2000 due to this GLP-1 drug shortage. So the compounding pharmacies have become an alternative for employers for a significantly less cost. So what we are suggesting is also what other employers are actually doing in other parts of the country. They're looking at this, the sourcing through compounds as an option for their members. These are all the new GLP-1s that are actually in the phase of coming out in the marketplace, just in trial phases, not yet approved by the FDA, but expected to be approved. So the pipeline is large and long. So now getting to where we're at. So this is getting to just a kind of a summary of what we looked at in the Ozempic, the Wegovy, the Mounjaro classes, what our cost per script is, and what the plan is paid per script. And we'll share some of this as to kind of our recommendation here in just a minute. But right now, there's a retail pharmacy component to this, and then there's a mail order in terms of the plan design. So in other words, if someone does qualify, how does it work? What is the member experience on a cost share? So right now, which we've discovered in the last 60 days, probably 30 days, Blue Cross has classified these diabetic GLP-1s as a value-based drug. What does that mean? All of our members that meet that qualification for a GLP-1 that are a diabetic at the same time, they pay a $5 copay for $1,000 to $1,100 drug. Why they did that, I don't know, other than they decided to put all diabetics, drug classes in the value-based purchasing. I can tell you all the other carriers across the country are not doing that. They put them into a formulary brand classification, which I'll show you what that means in terms of our plan design in a second. But the fact that they're listed at $5, that's why we have huge demand. Anyway, just so you know that it is the context of what's going on, of where Blue Cross has put. That's Blue Cross in North Dakota, not Blue Cross across the country, but Blue Cross in North Dakota. So what we are suggesting, and in fact, most other carriers actually have these GLP-1s listed as a brand formulary. So what does that mean? If they were on our plan for a diabetic class, they'd be paying a $25 copay plus 20% of the cost. Well, that's more in line for a member cost share. And then you can also have it as listed as a non-formulary if it's an obesity drug, or an anti-obesity drug. So that would be a 50% sanction plus your copay. So you can kind of see what the industry is doing in 1 and 2, and the recommendation that we have is, which is going to require this board action on 1, 2, and 3. They're listed here. So we are recommending that the Ozempic and Mounjaro that are a diabetic, type 2 diabetic class, that they would be listed as a formulary brand at a $25 copay plus 20% coinsurance cost share. So that is the one recommendation. Number 2 is the anti-obesity drugs classification, not be covered unless they're pre-authorized by Digby Health. So if a person wants to go get Wegovy for weight loss, they can, and they can go completely outside the plan and they pay 100% of the cost, whatever that is. But if they want it, and they want the plan to be considered paying for it, Digby does the pre-authorization. And then if they qualify, then they would they give them a pathway that says you can go through the retail, which is now a $25 copay and 50% cost. That's your one option. Or you can use the compound resource, and that would cost you a 0 copay for a 90-day supply. And if you're on an HSA plan, it's a $25 copay for a 90-day supply. And if they and you even offer the diabetics that instead of them paying the $25 copay and 20% of the coinsurance, they can also access it through the compound at the same basis of 0 copay plus the 90-day supply, or for 90-day supply, or an HSA plan at $25 copay. I just did just a quick summary of estimated savings just on cost if we did that. Based on the delta, and I use the average of 12 months for the compound. It's actually cheaper for the first 3 months than's listed here, but patients have to titrate up. In other words, they use more of the drug over time. So I did the average of a year compared to our current cost. And if we just did 30% of those that are diabetics moved to the compound, and 90% on those that are using it for anti-obesity use the compound, that would save $527,000 for the plan based on last year's utilization, not forecasted to more individuals that would come on. So I'm going to stop there, and covered a lot of ground, and now it's time for questions.
So board members, the gist is, as you've seen, $5 copay, the drug costs $1,000, give or take. We're losing lots of money. And so I'll maybe stop. Any clarifying questions on what was presented by Randy?
This is Kevin. When does that take effect?
Good question. Okay, so if we, so we're required, for any plan changes, we have to give a 60-day notice to members by law that says if you're going to change my plan, you have to give me that 60-day notice. So that's one window, 60 days. But we also have, we're counting on essentially a 30-day window to get all of our processes and coordination with Blue Cross finalized, because we got to get them to make these changes too. And so we're really looking at probably a 90-day window, from February. So you're looking probably May 1st as to the effective date for the change.
So Randy, when you make these recommendations, and obviously other people like yourself across the country are trying to respond to GLP-1 drugs. I mean, is this like best practice as far as how or are we just sort of like thinking about like this should do it to get them to do it?
Well, yeah, so that's a great question. That's the reason why we participated and reached out to so many different resources to kind of make sure that it was consistent with best practices. So that one slide I showed you that said, what's the industry doing? We're pretty much following alignment to that. We are only making it available for anti-obesity if it's pre-authorized. They have to do lifestyle participation. And if you do want it, if it's not pre-authorized, you pay for it yourself. If it is pre-authorized and you qualify, then you pay, and you want to get it to the manufacturer, then it's the 50% cost share plus the copay. And the same thing for the diabetic class. No one's covering these under that $5 copay value-based thing that we ever came across. Everybody's pretty much gone to, it is a brand formulary drug with a cost share.
Randy, the question I keep getting, Randy, would be, if we would have stayed outside of obviously NDPHIT, just stayed with Blue Cross Blue Shield directly with NDPERS, how are they handling it? Because that's what I always keep getting asked, is the comparison of what we would have been versus where we've gone today. And we understand we have rate savings, but we're starting to hear a few things on the pricing might be a little bit different. So I was just curious, how do they handle it as a competitor of what all of our, I guess I'll call it clients or members are used to?
So you have well, you have a couple, so it's basically, they could be either with Health Partners, United, Sanford as options. Okay, let's say they're in any one of those, that they have those as their option. So we'll start with Sanford. It's my understanding that Sanford doesn't cover it as a anti-obesity, period. So that's the one class. If they're with Health Partners, they don't cover it for anti-obesity either. They do cover it as a value-based, not as value, they cover it as a brand formulary, like we're recommending. That's what Health Partners and United does. And Blue Cross, they're not a fair comparison because they don't even, I mean, they haven't figured it out that there's just a huge issue that they're causing their employer groups to bear that cost. And the entire industry has moved away, from what they're doing in terms of the way that they're looking at it. They just have, all they're doing is pre-authorizing qualification if you're a diabetic or not. That's it. So they're not managing the patient, even if you're anti-obesity or diabetes or diabetic. And they haven't moved any of the class of a pre-authorization for the anti-obesity requirement. Other than you have to be a BMI above, I think it's 27 or 28. I mean, there's basically the bar is very low to qualify for what Blue Cross would approve for today. And that's why we see in our data so much utilization on the Wegovy.
How much will this help for our increases for next year?
Well, yeah, so the problem is we're by the time we get it implemented, we're going to lose 5 months. So that's, so you have to take a prorated approach to our savings. But even if we save $300,000 to $400,000 between May and the end of the year, that's $300,000 to $400,000. And that does, so the forecast that this shows, that's what I've shown is just the cost savings. That's not showing the other intervention that Digby's doing. But it's going to be a prorated number between May to the end of the year.
Brandy, I apologize if everybody else knows the answer to this and I don't. But what is a compound pharmacy?
Compound pharmacy it's an FDA. Basically, they have to be licensed by the state, and that they're overseen in terms of the processes by the FDA. And it's a mail order is really the function of it. It comes via mail order versus going down and retailing, to the local pharmacy.
Thank you.
So is that a lot of work? So if for the diabetics that are paying $5 and the trust is paying close to 1,000 or 900 or whatever for that, we can save a lot of money, the trust, by having them do the compound pharmacy, and then they can still get it 0 or 25. But how much work is that, and how are they going to be calling us to figure out how to do that?
How to do what?
Find the compound pharmacy?
Oh, no.
Or,
Remember that all comes through the Medalis and Digby thing that they.
but I didn't think the diabetics had to went through.
They have to go through if they want. If they want to use that source, they actually have to go through the Digby program to coordinate that patient care and the procurement of it.
Even if they're diabetic.
Yeah.
Okay.
Because that's what we're trying to do, is we're trying to engage those members. And so what are they going to be motivated for? I can save money on my cost. So I'll take it at a 0 cost copay versus my 20% that I'd have to pay.
I think unfortunately, doctors aren't gonna stop prescribing these things. And maybe this might make people think about taking these for anti-obesity. If we do they have some stake in it. That's my thoughts.
Yeah, clearly for anti-obesity, where the industry has gone is a lot of the carriers just say, we're not covering it. And so employers are, it depends on the kind of industry. You know, I would say each employer just is deciding how they want to do it. Some are a lot of them actually are self-funded or continuing to do it, but they put in the other protocols, pre-authorization, step therapy, management of lifestyle. So they're saying it's available, but we're only going to make it available if the patient is actually engaged to change.
So Randy, if we go with this option, is there going to be educational pieces that go out to our member group?
Oh, yeah, I haven't got to that yet. That's next, Desi. Yeah, I'll show you what, the first thing is deciding, okay, do we have the ability to go forward and make because we have to make these plan changes in order to make the other program work, in order to get the engagement. So we've already, the prior, board meeting was to approve Digby that they can do it. Yes. So what we've done on the anti-obesity is going to make that happen. But as a result of that, we also have to make a recommendation for the plan changes, and especially in the value-based component, going from the $5 to the $25 copay for the brand and the co-insurance for that, for the diabetic class.
Okay, any other clarifying questions? Do we have a motion?
I'll make the motion, Kevin.
Kevin made the motion. Do we have a second?
I'll second it.
Desi with the second. Further discussion? Further discussion?
Recap me the motion just so I'm clarifying it, because I've been kind of all over the place here. So I just want to make sure I'm sure what we're voting on.
Kevin, from what I understand, you were motioning what the moving forward on item 1, 2, and 3, which would require more skin in the game for those that are using those prescriptions, Ozempic, Mounjaro, and then the anti-obesity drug of Wegovy and other GLP anti-obesity drugs. $25 copay, 50% sanction per script. Number 3, if they want to maintain on that, and they basically agree to get those items from the compound pharmacy. And then of course follow what Digby is trying to get them to get in a better, get them more healthy and, and eventually hopefully get off of these drugs.
Yeah, that's what my motion is.
Okay. Brennan?
I've got just a question. When folks get on these drugs, is there any long-term, like I suppose there haven't been any studies as far as like long-term, do they stay in a weight range that's healthy, or is there kind of
that's
a rebound where they got to stay on it long-term just to maintain the weight that they've lost? How does that work, Randy?
If the study showed, Brennan, that if you're not in a lifestyle program, within 1 year, you'll have gained all your weight back. And so that's why you can't do the programs effectively without a lifestyle intervention and clinical management of the patient to what Mike said earlier. And that's what the Digby program is they want them to get off the drug completely.
Okay. Thanks, Mike. Thanks, Randy.
Further discussion? Any discussion? Maybe, I don't know, do we do a roll call on this one? Just so we know. You want to do that, Brenna?
And I can see you all. I'm sharing.
Stop share.
Yeah.
Okay, I'll stop sharing so you can see.
All right. I'll start with Cole.
Can you hear me?
Now I
There we can.
Okay, yes, I said aye.
Brennan,
Yes.
Desi,
Yes.
Kevin,
Yes.
Sonia. Can't hear you, Sonia. Maybe Sonia's distracted. Mike,
Yes.
that's it.
Sonia voted
Yes,
yes.
from Sonia. All right.
Okay, motion carried.
Yes.
Okay. I believe we still have item C, is that correct? Change to PPO discussion?
Yeah, I've got that, let's see. So I'm gonna, just give me 1 second, and, I've actually just. A second, I got my slides down here to get to it. I'm going to. I'm gonna combine this as kind of other items. So there's really these other items, so. For, one of them does require us to get a vote from the board. We brought this up in the past, and the question is, should we do a carrier RFP in 2020 for 2025? Which, what does that mean? Basically, you're taking it out to bid for our administration, our stop loss, and our PBM. Who would that go to? Health Partners, United Healthcare, Medica, and Sanford. So if historically, with some of our other large self-funded groups here in North Dakota, we have done this for, with I would say the majority of them in the last year and a half to 2 years. It's been a very helpful and I would say competitive value to the employer, whether they stayed with Blue Cross or they or they considered moving. What it ended up doing is competition for, especially in the area, admin and PBM structure, as well as stop loss, it's always helpful to have competitive information when we are in our negotiation for the renewal. So it's more of a question. It would take 60 to 90 days to actually go through this exercise. It's actually a pretty heavy lift when we go through it. But it's, this is part of the purpose of why we do what we do. And so we're asking for some direction as to whether that should be considered for us to take on as a task. That being, in this case, it'll be both the Brown and Brown team as well as working with Seek as we go out to the market to gather all this data and to get all these quotes put together. Any thoughts or comments about that?
Just want to make sure I understand. So, I mean, is this the idea of shopping around and not staying with Blue Cross? Am I correct on that?
Well, yeah. So the idea is basically it's what I call the kind of the market check.
Yeah.
And say, for due diligence, do we say let's go and really investigate the market, so that we know where we stand in terms of our competitive pricing. That historically Blue Cross has been the only one that's really offered any association and trust business in North Dakota. However, in my prior experience, even before working on this trust, we did a trust with Health Partners. It was a public trust that's it's in Minnesota, so they know how this works and they do a great job. They're an option. United Healthcare is an option. Medica or Sanford may not respond to it because they have to have the infrastructure that can manage a trust program. But certainly we would get quotes from, I think, from Health Partners United and Medica to look at and evaluate.
Just some thoughts. I mean, and I don't know, like, is this a timing thing? Personally, I would like to have maybe just some more information on this. Especially like a face-to-face meeting, to be honest with you. Like, I mean, so if we approve this, you would get rolling on this. Do you need it before March 27th? I mean, what's the time frame?
Yeah, so maybe to answer that question, Mike, what we would do is come up with the RFP parameters that give you the scope of what it would encompass.
Yeah.
And then if you kind of gave us final, approval to move forward, we would take that, because it's a pretty lengthy document. So it's going to take some study for everybody to look at it. And then, maybe if it's the idea is just said, give us this RFP template format. And then we'll, ultimately maybe as a follow-up, if everybody's comfortable with it, they can give a follow-up, approval in an email format after they've had a chance to all review. And then if that's when it's decided, then we can release it at that point.
Randy, this is Cole. So I wasn't part of this when it got originally developed, but I'm assuming this is what took place in 22 or 23, that an RFP similar to this was done, and now we're going through our 3-year process.
Yeah, so that's a good question, Cole. Going back to what I said earlier, even prior to 23, there's 2 things that affected the marketplace when we first started. One is Health Partners, who's the only, United does it, but they're not as, their structure is probably not even as advanced as Health Partners, to be honest. And so when it was originally created, these competitors did not have enough footprint for a provider network to even be competitive with Blue Cross at the time. So if you wanted access and there's still some limitations even close to Dickinson that these carriers have limitations on. When I say limitations, they probably don't have as a competitive contract. They have a contract, but that's all part of the evaluation. But at the time, even having a contract in Fargo with Health Partners and United being competitive didn't exist. In just the last 3 years, the evolution of the market has changed dramatically. So Health Partners, United, and Medica have all made significant inroads. And Sanford, at the time, and also historically, they've never really been competitive in the self-funded market. Even today, that's just not what they do really well. So none of these were actually looked at because Blue Cross really was the only alternative at the time.
Okay, so I'll make a motion to create the 2025 RFP and then present that back to the board for final approval to proceed.
We got a motion to create an RFP to review. We have a second.
I'll second that, but then I've got a question for discussion.
Okay, discussion.
Randy, so how much work would it be to create that RFP ahead of board approval? Is it worthwhile for us to do it this way, or would you rather have full board backing before going through the creation of the RFP?
We already have one created. Yeah, so we've done enough just recently, with whether it's West Fargo Public Schools or Grand Forks, we did it through. And I mean, we have several groups that we've actually got a pretty well, we'll have to make some modifications to it, but I think that within, fairly short order, we would have something as a document for everybody to look at.
Okay, so then the process would be you guys bring the RFP in March and then we give the final, yep, let's go for it.
Well, actually, we bring it forward sooner. And because if we're going to look at it for 2025, we probably want you to have that document as soon as you can, so that we can start working on it even sooner. Because we're actually, if you think about it, we're going to be releasing the rates for the the school districts by May. And so in order to do that, that's part of our negotiation with Blue Cross on the renewal.
Gotcha.
So that's,
So is there any downside? I mean, have you seen Blue Cross Blue Shield or other carriers when an RFP process is underway? Or is it pretty much standard procedure that this happens and so everybody rolls with it?
Well, it was a standard procedure, but it is now. Blue Cross is now realizing they got competition.
Gotcha. Okay.
And there's nothing wrong with that. And so the down, we haven't seen any downside of all the ones we've done in the last year. It's all been to the benefit, to those, both to the plan as well as to the members. They've actually stepped up in several areas, that being Blue Cross, and made it more attractive for pricing, but also expanded some of the services.
Gotcha. Okay.
So just does this impact coverage network, Randy? Like if we make a switch and then now, like what is that?
So that would all be part of the final report, Mike. That's all part of the analysis we do. It's called a disruption analysis. So what we would be going through is basically putting all the data points together and bringing it back to the board for review. And whether there's a decision to actually move or not, it's probably, I mean, that would be, ultimately could be the decision, but just to go through the exercise, there are many points, like what you just mentioned, where we found it has been a valuable instrument to bring competition and to the pricing for Blue Cross, as well as to the others that come to the table.
Randy, the reason why I just wanted to look at the RFP, so like when Mike had mentioned, I just kind of want to know what we're advertising, so we're not maybe missing something. But I also don't want to slow you down and lose weeks over this either. So,
well, and I don't, my comment, maybe I think I misunderstood. I mean, if we're just going to be able to look at options, we don't have to just take one, unless it makes.
No, not at all. That's not what this is.
That's not what this is about. So I don't want us to. I didn't want to sway you guys now that I understand this a bit more. So maybe we need to move faster if that's what you guys want to do.
Well, I'm willing to amend my original motion to approve the 2025 RFP, but I would like to see a copy once it's completed. Even though you're going to proceed with the RFP, I'd like to review it while it's out there.
Yeah. Okay.
And I'll second that amended motion.
Okay. Further discussion. Further discussion. Let's just do another roll call there, Brenna.
Cole, yes. There's only 4 of us.
Oh, Mike,
Is
yes.
there only 4? Is that that's not enough then?
Sonia, yes.
Oh, I forgot she's on.
Okay.
Okay, I can't.
Kevin, yes.
Sorry.
Brennan, yes.
Take care of it. Oh, Desi's still on too.
Bessie, yes.
Oh, Kevin's there too.
Kevin, you say?
Yes.
Thank you.
Okay.
Got him.
So
Okay. Oh, sorry.
you'll be providing this at some point to us to review. I don't like, so by March 27th, what would we have? Would we have examples?
Well, what we
Motion.
would produce right away is the document. That would be first. And then we set a timeline in that document. We usually give, once it gets released to the marketplace, we usually give 2 weeks, 2 to 3 weeks for the carrier to respond with all the required data points. They're used to responding to RFPs, so they know typically what to expect. And Angie, who's here with us, she's been through this a couple times, so she knows firsthand what it means. And it is a process, but it's more work on their end. Once we have everything back, then we'll do the tabulation of it all. But by that, so what we hope to have is everybody having a chance. When we send this RFP template out, we'll set a timeline that we'd like to get responses back, just to say, I'm okay with it. And we aggregate it and everybody's fine with that. Then we would just get a final approval from, the board chairman that says, yes, everybody's good with it, and then we'll release it. And then give probably a 3, maybe 4-week time period for the carriers to get us their responses. And then we would take those responses and then give a summary report to the board for review by the March 27th time period.
If we did change carriers, what kind of process would that be, letting all of our members know?
Well, okay, so all those kind of questions, Kevin, I'm going to ask that we hold off on, because this conversation could go deep and wide fast. So I think what, for the context of the board, to maybe consider is just let us come back with the high level of what the value of what we can leverage in that process. More so than making the idea of every incremental change and making a change to a plan. So that's the way I would look at it. This for doing this is and because this is being recorded, I don't want to. I want to give more information that maybe we do separately, I guess is what I'm saying.
I'm okay with that.
Okay, so we have some direction. We will wait to hear from you on that. I'm going to move on to financials. And it's Stephanie that goes through this.
Nora.
Sorry, Nora.
Oh, it's okay.
Oh, hi, Nora.
We did have the November financials in your board packets. Those were sent by Brenna. We don't have the Decembers because the Decembers we'll need the actuary to do the IBNR reserve calc yet. There's also a true up for the premium or the pharmacy rebates receivable. We do the estimation based on the guidance that we got from the auditors last year and how to estimate it, but there's always a true up. So that could change as well. So we didn't want to put the December ones out there since there could be a couple significant changes yet that we're waiting on, and we won't get those probably till closer to March. So hopefully for the March meeting, we'll have the December financials that will be audited by the auditors later, but that is when the actuary is going to be working on it as well as March. So we did November's financials, and then I'll kind of give you an update on what we do know in December. But as you can see, total assets were at over 9.8 million at the end of November, with most of that being in cash and cash equivalents, some of it in those pharmacy rebates receivables. We did move more funds into CDs in December, but as of November, there was about 1.5 million in CDs, accruing some more of that interest since we were still getting good rates. The IBNR reserve, we still left. Again, we haven't adjusted that since the end of last year. More than likely, with more people being in the plan and the cost of the plan this year, that will be increased. But we're going to wait until the actuary has a chance to look at our actual figures for the year to give us what that estimation is. But even if that goes up, we're still looking at over 5.4 million in membership equity. So sitting at a good place financially, but very liquid and stable right now as far as equity. If you look at the income statement side of it, you can see the earned premiums, been fairly consistent throughout the year. We only had a few groups added in October. And so we're at earned premium of 4.7 million in November. Through the year, 50.3 million in total earned premium. That's less the stop loss premium that we pay as well. But out of that, 47.8 is in the actual premium. We have almost 2 million booked in rebates through November. So we're getting some other extra funds and revenues coming in during the year. You can see our loss ratio through November is at 94% for that month, up to 96% loss ratio before IBNR at that point in time. Again, we haven't adjusted that this year, so that will increase a little bit. Operating expenses, we stay really consistent throughout the year. 3% operating expense ratio. You can see one thing that's nice is this year we got over 271,000 in interest. That includes the CDs that we're doing, but then also just the better rates when we moved over to First International. So that's an extra couple $100,000 that we're able to receive just by putting the cash that we do have on hand to a little bit better use. MetLife collections, those are all in and out, but through the year so far, through November, we're looking at $755,000 net earnings. So to the positive this year through November. So that has been good. Pretty good spot. Again, those will adjust. Our IBNR more than likely will increase, but we also might have some more rebate revenue from the true up that isn't currently booked. And we only book it quarterly, so there is more in December. That there is one nice thing in December this year due to that rebates revenue being booked. Just to give you a heads up, those financials aren't out there yet because they're not final, but just so we know, our loss ratio, that took our loss ratio down to 91% for the month of December, which there was a lot of expenses going out in December, as there usually is, because people are trying to get those costs in before year end, since the deductibles have been net, things of that nature. So it did take our loss ratio down. It's still at like about 96%, but December compared to what happened last year in December, you know, that's a good look having that extra revenue in there. And again, through the year, 3% operating ratio expense. So those, we keep those costs down, keep them consistent. So tentatively, it, you know, like I said, without the IBNR reserve, I don't give you a net earnings number, but as far as actual loss ratio before IBNR, it definitely helped out this year having some of those rebates receivables booked, and hopefully we'll have a little bit more in the true up. Sorry, that was really fast, but if anybody has any questions, let me know.
So this is Cole. This might be for Randy or Nora. And I don't know all the acronyms that we approved at our kind of in-person meeting we had over in Bismarck, but my question would be, with all the changes and the motions that we made for some of those different prescription drug differences and the obesity things we just did here, how does that relate to the financial statement where we actually can see a year-to-year comparison that the decisions that we made, we're actually seeing and reaping the benefits after we make those decisions? Because in my world, like if we make a price change or we do an adjustment, we track that. And how do we track that in an annual report? So we kind of know that the decisions we're making, we're actually making the profits or the savings that we're trying to accomplish. How do we do that, I guess, is my question.
One of the ways we will see it, and I won't have, you know, direct, because some of that's just going to be people not taking the medicines, us not paying as much for the medicines. But what we can do going forward, now that we've slowed some of the intake of it, is going forward for 2024, we can show a comparative year-to-date actual so that we can see on the financial statements, like, you know, balance sheet, it's not as much of a thing when you're comparing last year to this year because there's ebbs and flows with cash flow and things of that nature. But the income statement will really show us, like, if our loss ratio going forward in 2024 does take a significant dip because we're not having those same high level prescription costs. We're not having some of those same PPO costs or comprehensive costs because some of those things are coming into place. Our loss ratio should get better because we'll still be bringing that same kind of premium, but we're not going to have those same kind of costs and expenses going out for some of those things, especially one of those main things I know is in that prescription realm. I mean, through November, we had almost $10 million paid out in prescriptions alone. So, I mean, it should affect some of those ratios. And in 2024, like I said, just because there'll be more consistency in our pool, we can show a comparative going forward. So you could see, okay, last year through March, we were at this point. You can, and hopefully we'll see a turn, hopefully implementing these changes come, you know, May, June, when we start seeing some of those month-to-month returns will be seen when we can do the comparative.
That would be great. And I don't know if it's Randy or Brenda, but if we can kind of get an itemized summary of some of those changes we made. I mean, we can go through back the minutes, but at least when we meet in our annual meeting again, or in the summer, I'm assuming when we start getting ready to set those rates, I'd love to be able to see a comparison of what the implement changes that we put in place. And let's see what happened a year later and that we're actually following through in what we try to accomplish.
Yeah, so, Cole, relative to your question, actually, that's one of the things that we will be able to measure because we'll look at the prior year utilization specific to like Wegovy as one of those action drugs that we are, adjusting through pre-op. You can look at the number of scripts, our average cost per script, the number of patients on it, and then determine what's our unit cost savings per script, and then multiply that by the number of patients on it. Did our demand decrease, as well as our unit cost decrease? And then calculate what that value is. That is one component of our ROI that we will be measuring relative to the entire DIG program and these GLP-1 drugs.
And then last thing, and Nora's probably cringing when I say this, but do we do an annual report that we send to our members?
We have not.
I'm just bringing it up because we're in the middle of completing ours, and I know we're only into year 3, but I just think as we grow and we want to be communication, I mean, I'm just asking the question, is that something that we need to be considering? Not necessarily doing it now, the workload's probably not available, but moving forward, is that something that we want to do to educate everybody what we're trying to accomplish?
We've done that in the past. I know Randy and Brenna, I don't know if we did it last year, but I remember doing it.
Yeah,
The
As
first year
chairperson.
we did it.
yeah, so we could do an updated one on that one, Cole. That's a good idea. There's enough information out there that we could probably put a year-end report together for 23.
Thank you.
And what you could do, Randy, in this, if you're okay with this, Mike, I'm gonna move forward off the financials and just mention something real quick. So Brown and Brown and MetLife are going to be the platinum sponsor for the HR Collaborative Conference coming up in April that the NDRF is putting on. And as part of that platinum sponsorship, we're going to give them a session at the end of the conference where, Randy, you could unveil that annual report at that session.
Yep, that is a great idea. Yeah, we'll plan to do that actually, Brendan.
That sounds good. Do we need a motion to approve the financials?
I don't think we've ever had a motion to approve, but we certainly could.
I don't want to change process, so I'm good with not doing it. So,
Okay.
that sounds good, and I think that's a great. I like the idea of just the transparency. And I'm just thinking like, just the fact that like understanding that, and I don't think people really care because they were getting a good deal with a $5 prescription for this, but the fact that like it was $5 and it costs us $1,000, like that, just everybody's got to understand that that's not sustainable, and so I don't know if you tie those kind of, hey, this is why we did this, and that's, again, there's so many decisions we make in a year. I don't think we should, break them out that way, but if people are angry about that, then there's rationale anyway. So okay, I think we've finished our agenda, correct?
The only other thing I would say is that, just so you know, we're gonna send this out, and Desi's question about what our process of communication is in my slides that you'll have to see on the Digby program of how the program is communicated. So just so everybody knows that.
Do we have a motion to adjourn?
So moved.
Brennan?
Second.
Kevin? No discussion. Have a great day. Meeting adjourned.
Thanks.
All right. Thanks, Mike. Thanks, everybody.